Michael. Today we are going to talk on update on pulmonary hypertension, and our speaker is Dr. Shaheen Moledina. He is head of National Pediatric Pulmonary Hypertension Service and Pulmonary Hypertension Team, Great Ormond Street Hospital, London, UK. Over to Shaheen.
Well, thank you very much indeed, and I'm really honoured to be invited to join you at the annual meeting. I'm just going to try and share my screen, and I hope you will be able to see it. Please do let me know if it's not projecting. But yes, as I say, it's a great honour to join you from pretty cold UK. And to join the wonderful meeting and talk about an update on pulmonary hypertension. And thank you to the organisers for inviting me. When I was thinking about how to talk to a mixed audience of adult and paediatric cardiologists, I thought first that when we're thinking about an update in a disease, it's helpful to consider where we came from. And I think it's helpful to think of pulmonary hypertension as having gone through three intellectual ages. The first really probably started in the late 19th century and early 20th century, where pulmonary hypertension was really a disease of the pathologist and pioneers going back as far as Victor Eisenmenger, Wagenvort and Heath and Edwards described the pathology of the disease. Then really in the 20th century, starting with the invention of cardiac catheterization by Forsman and Cournard, and then subsequent application to pulmonary hypertension by Paul Wood. This is the middle section is a slide by Paul Wood. I think we entered a physiological age where we were describing the disease in terms of its adverse physiology, and really the definition of pulmonary hypertension stems from that. And I'm going to argue today that we're entering a new age of pulmonary hypertension, an age of precision medicine, of biological and big data. And I think this is a very exciting time for young scientists to join the field. So if I were giving this talk, or if my predecessor was giving this talk some years ago, the pace of change was really quite steady. And perhaps we could have done an entire talk in 20 minutes. But there's really been rapid developments in pulmonary vascular disease understanding, and I'm going to just pick out three areas to discuss with you today. And the first is the definition, which, as I said, derives from the physiology. The second is the burden of disease and our increased understanding of the burden of pulmonary hypertension in general. And finally, I'm going to try and touch on our developments in precision medicine and precision understanding and assessment. So as I said, pulmonary hypertension is a syndrome of raised pulmonary artery pressure. And this echoes what comes to mind often when people think about pulmonary hypertension. Whilst its antecedents were pathological, this is one of the first gatherings to discuss pulmonary hypertension in a more systemized way. This is the WHO meeting held in Geneva in 1975. And this is perhaps where the definition was first agreed upon. And we can see I've highlighted that although it was understood even then that the pulmonary artery pressure never exceeds 20 millimeters of mercury in healthy adults, as they've stated, the group, and it was a small group, decided at the time to define pulmonary hypertension as pulmonary artery pressure exceeding 25. More recently, various groups have tried to put together data from normative data, and this paper is in the European Respiratory Journal, and it systematically reviewed 47 studies with over 1,000 individuals with normal data at rest and exercise. I'm just showing you the rest data here, to clearly define that the mean PA pressure in a healthy population is around 14, and 2 standard deviations from the mean gets you to 20. So normal hemodynamics, the pulmonary artery pressure should be less than 20. Of course, deviation from normality doesn't necessarily by itself define disease, and I understand you had a nice session with Brian Williams and others talking about systemic hypertension. So to that end, Bradley Maron in Boston, and then subsequently a couple of other groups have looked at bigger data, and this is where we have the advantage of now access to larger scale data. So in this paper, they looked at 21,000 cardiac catheter studies in the Veterans Affairs database for all comers with any comorbidity, and showed very nicely that for a mean PA pressure above 19 millimeters of mercury, there was a continual increase in risk of mortality and other adverse events for increments in pressure beyond that. So I think it's been quite well demonstrated, therefore, that pulmonary artery pressure above 20 is both abnormal and is associated with abnormal health outcomes. And with that in mind, at the last World Symposium of Pulmonary Hypertension in 2018, or published in 2018, the hemodynamic definitions of pulmonary hypertension were revised, and the proposal was that the mean pulmonary artery pressure above 20 would be considered to be pulmonary hypertension, and then stratified upon resistance and the wedge pressure, defining which type of pulmonary hypertension you have. So that's the first development. Then, of course, this all started with consideration of primary pulmonary hypertension. And in fact, in the first proceedings of the World Symposium, there was reference to a large case series from Sri Lanka in 1975, which was one of the series of data on primary pulmonary hypertension which prompted or fed into this discourse. What subsequently happened over the years is that our understanding of the phenotype of pulmonary hypertension has broadened, and what it settled into initially was this more broad classification of pulmonary arterial hypertension, pulmonary hypertension due to hypoxemia and lung disease, left heart disease, chronic thromboembolic disease, and multifactorial mechanisms. Given that the substrates, especially left heart disease and lung disease, are very common, it was then thought that it would be important to see what the global burden of disease is. And this is, again, where things have developed somewhat in our understanding. This is a nice review of the global burden of pulmonary hypertension. And we can see globally, left heart disease is the primary cause of, or leading cause of, pulmonary hypertension of any type, followed closely by lung disease. And the authors estimated a global prevalence of about 60 million people affected with pulmonary hypertension of some form or the other. Of course, because of our previous, or the community's previous focus on group 1 disease, they also looked at group 1 disease and the breakdown of group 1 disease. And this is where it's really important to consider populations distinct from the European and North American populations in which many of these guidelines have been developed. And we can see in Africa and Asia, and to a lesser extent in South America, congenital heart disease is one of the leading causes of pulmonary arterial hypertension, and is, I would say, relatively understudied as someone who spends a lot of their time focusing on congenital heart disease, pulmonary arterial hypertension. So where does that take us? That of course, that tells us that there's a global problem, and that it's been under-recognized in communities out with the West. However, every challenge is also a potential opportunity, and I've just displayed here the population distribution of Sri Lanka versus the United Kingdom, and you can see that the population in Sri Lanka is younger. And in a sense, I would argue that some of these forms of pulmonary hypertension, left heart disease, lung disease, and pulmonary arterial hypertension, congenital heart disease, offer a potential for primary public health interventions to prevent the development of pulmonary hypertension. And these have to be done at a younger age. So there is a potential opportunity. So I'm a pediatric pulmonary hypertension specialist. So I'm going to just interweave some pediatric data where I can, and this is data from the UK on the incidence of idiopathic pulmonary arterial hypertension in children. So the UK pediatric population is about 13 million, which is somewhat less than the entire population of Sri Lanka at about 20 million, 21 million. And so these are our estimates. And I wanted to partly show this because, as I said, much of the work, and I'm going to show some genetic work in a moment, has focused on European and North American populations, many of whom are of European, or the majority of whom are of European ancestry. And these are data from our pediatric cohort. And you can see this is the UK population breakdown, so the majority Caucasian. But when we looked at our idiopathic PAH, there's an overrepresentation of patients from Asian descent. And that will prove important when we start pursuing precision medicine and considering the genes that are involved. So I'm going to just skip over this in the interest of time, but the other understanding that's happened with the burden of disease is that historically we've simplified the classification of disease into the groups that I showed you earlier, but there is an increased understanding, and I would argue that this stems largely from the pediatric cohorts, and this slide is attributable to Maria del Cerro in Spain, that patients can exhibit features of more than one group. So they can have features of left heart disease and elevated resistance and lung disease, for example. And I'm pleased to say that more recently, this is a graphic from the PVRI, Pulmonary Vascular Research Institute, which I'd highly commend to anyone who's interested in pulmonary hypertension. More interestingly, there's been a realization that actually even in adult cohorts, the phenotypes can cross and can have features consistent with group 3 and group 1 or group 2 and group 1. And this may allow patients in some of these groups to benefit from some of the advances that have happened in group 1 disease therapeutically. And this is the classic example from pediatrics of TBX4 variants. So these are variants in one of the more common genes for pediatric pulmonary hypertension and a reasonably common gene for adult pulmonary arterial hypertension. But the important message from this genetic variant is that despite having the same genetic variant, the phenotypic presentation can be very different, with some patients looking very much like they have idiopathic pulmonary arterial hypertension, whilst others have a phenotype of interstitial lung disease, despite the same genetic background. Which brings us to the genetics of pulmonary hypertension. And pulmonary hypertension has really benefited from developments in high throughput genetic testing. This is a schematic which, although is not very old, is already outdated in terms of genetic discoveries in pulmonary arterial hypertension. Some of these genes have subsequently been found in other forms, in patients classified with other forms of pulmonary hypertension. So large-scale genetic testing, whole genome sequencing in large populations has allowed the discovery of genetic causes of pulmonary hypertension. And beyond that, the reason that is important is because it has therapeutic implications. And of course, the first genetic variants from relatively small scale initially studies and segregation studies really identified variants in this important pathway, BMPR2, but subsequently variants have been discovered in numerous other pathways, nuclear transcription factors, potassium channels, on the endosome. And these have potential therapeutic implications. And again, I think I could have put some more arrows. I'm going to show you very briefly a couple of studies, just more to give a flavor of how this will have therapeutic implications. So already the BMPR2 pathway, which is the most mature pathway, has been targeted by numerous agents. But now, with understanding of other pathways important in the development of pulmonary vascular disease, newer agents are targeting disparate pathways, giving numerous therapeutic channels. And this again takes me back to the earlier slide, which really highlights the therapeutic importance of studying populations who are not genetically, or who are genetically diverse, in order that we don't systematize therapeutic disadvantage. So I'm just picking out two studies which have really leveraged the genetics of pulmonary hypertension. The first one was a phase 2 study by Michaelis in Canada and Martin Wilkins' group at Imperial College, and they used dichloroacetate as a therapeutic agent, primarily for right ventricular function and to modify the pulmonary vascular resistance. But what they did was they looked at common variants, so SNPs, involved in the pathway, and were able to show that by targeting the drugs to the right patients, or post-DICT, that patients with a higher SNP score had, or a lower SNP score had a more impressive result from the therapy, thereby potentially allowing targeting of therapy. And then I couldn't resist. I'm not involved with this company, but I couldn't resist showing this latest study, which I suppose is the first phase 3 study targeting the BMPR2 pathway. As I said, this is the first pathway defined in pulmonary hypertension, and this is the first phase 3 study which shows that targeting the pathway with sotatercept, which is a ligand trap for TGF-beta, can modify pulmonary vascular resistance and improve walk distance and clinical symptoms in patients who are already on background treatment with combination therapy in many of the patients. So just highlighting the importance of precision medicine. And on that note, for the last minute, I'll just show you other advances in large-scale data and precision. So this is CardioMEMS device, which is an implantable pressure monitor licensed for use in heart failure, but also used in pulmonary arterial hypertension. And devices such as this and wearables are now being, and implantable link devices are being used as a way of getting much higher fidelity data on patients with pulmonary hypertension, which then will feed into clinical trials. And I highlight a phase 2 trial running in the UK, which is going to leverage some of these technologies to permit powering a study with relatively small numbers of patients. So on a final note, I would say that this is an exciting time in pulmonary vascular disease. I've only highlighted 3 rough domains of developments. I would encourage young investigators to get involved in this area, not least because there is an unmet need globally for developments of pulmonary hypertension specific to communities out with the West. And I've just put a little plug for the Pulmonary Vascular Research Institute. And on that note, I'll say thank you and end my talk. Thank you very much.
Thank you very much, Dr. Molledina, for that very extensive and brilliant lecture. Since this is a plenary, we don't usually entertain questions from the audience. However, just out of my own curiosity, if I may ask a question from you, with regard to patients with pulmonary hypertension, what is the frequency, I guess, that you've seen patients who actually have resolution of their pulmonary hypertension with treatment? Does it happen very frequently? And how would you tail off their medications in that way?
Oh, that's a fantastic question, especially for a pediatric cardiologist, because it's something that we do see in pediatrics. I think it's probably, I don't practice in adult pulmonary hypertension, but I suspect it's very much less seen in adult pulmonary hypertension, especially in pulmonary arterial hypertension. But the areas where we've seen this consistently is to the population with the greatest propensity to resolve is probably the young infants with developmental lung disease, and the lung seems to have a great ability to develop postnatally for the first few years, and we've seen resolution over the course of about 1 or 2 years. And then the other group is patients with pulmonary arterial hypertension related to congenital heart disease, and this, if it's operated in a reasonably timely fashion. And I really think in pediatric populations in countries with less well-developed primary care and public health access to congenital heart disease surgery, this is probably the area where you'll get the biggest bang for your buck in terms of preventing or encouraging the resolution of pulmonary hypertension. In terms of when we wean off therapy, there's really, to my knowledge, very little published about this. And at least at our institution, we tend to take a very conservative approach and want consistent demonstration over the course of 6 months to a year of resolution non-invasively before weaning, and then confirming resolution by cardiac catheterization.
Keep on monitoring them? How frequently would you get them back to clinic, for example, to make sure that the pulmonary hypertension is indeed resolved? Once a year, maybe?
Absolutely. So rightly or wrongly, once we've demonstrated normalization of pressure and resistance by cardiac catheterization, the then put them back into the routine cardiology follow-up regime, which is probably once a year. What we don't know is whether there's a later reoccurrence of pulmonary vascular disease. And I have to say, as I said, it's really understudied disease, especially here where the numbers of patients who present with some form of pulmonary vascular disease due to congenital heart disease is low. But once it's resolved, we probably see them once a year.
Thank you very much, Dr. Molledina, for taking time off your very busy schedule, I'm sure. And hopefully in the coming years, you'll be able to visit our beautiful country as well, rather than seeing you virtually in the UK. And we'll always welcome you back to Sri Lanka. And that ends the plenary as well, and we'll carry on with the sessions.
Thank you very much indeed for the invitation.